I'm here to introduce Dr. David West. He's a family physician, just like many of us, and as many of us are aspiring to be. He has practiced in all areas of family medicine. He's worked as a practitioner, he's been a teacher, a program director, and a dean. He's a patient advocate. In Colorado, he was a leader for passing tort reform bills. He's helped with living will legislation. Currently, he is the Vice President of Medical Affairs at Hospice and Palliative Care of West Colorado. He believes in universal health care for all, with an emphasis on cost-effective and quality care. He emphasizes preventative medicine, and he believes in hospice and palliative care for everyone. Please welcome Dr. David West as he gives an example of how physicians can lead a community.
Good morning. It's a pleasure to be here, and I want to thank the FMEC for this invitation, and particularly thank Larry Bauer for his help and guidance and suggestions to me before this talk. But everything I do say, I take responsibility for, and if you want to know where I came up with some of the things I say, I'll be here this morning to answer questions. I am a family physician. I'm proud to say that I've delivered about 1,200 babies over the course of my 30 years when I was delivering babies. I took care of people from cradle to their deaths in Grand Junction, Colorado, and had the pleasure of having kind of my hobby for almost all those years to be looking at our healthcare system and how we can make it better, both locally, statewide, and nationwide. And as I start, I just want to let those residents and medical students here today know that my generation has not fixed the U.S. healthcare system. We've made a few inroads in a few areas, but you really do have your work cut out for you, and Godspeed in doing that. T.R. Reid and Ted Epperly preceded me the first 2 days, and they are outstanding speakers. T.R. Reid talked about sick around the world and the different models of healthcare that we all practice under, and he didn't make a plug, but his video called U.S. Healthcare, the Good News, really talks a lot about Grand Junction and why we were successful from a reporter's viewpoint. He also he talked about those 4 healthcare systems, and one other that I would add to it is we also have the EMTALA system. That's the Emergency Medicine Treatment and Labor Act that was passed when Ronald Reagan was president, and that's the law that said when you come to an emergency room of a hospital that you will be evaluated and treated for your condition. The problem with that approach to healthcare was there was no payment for that type of healthcare. So this is Grand Junction. Quite a bit different than what the territory here, and this was in the Kaiser Health News, still the poster child of healthcare. We became famous in 2009 when Dr. Atul Gawande published an article in The New Yorker called The Cost Conundrum. And in that, he compared Grand Junction, Colorado, and our healthcare costs to McAllen, Texas, and the difference in cost is about threefold, and yet the health measurements in Grand Junction were better. And that led to a sequence of events that have really brought Grand Junction into prominence. And so I'm going to tell you the story of what happened. I want to say that what I'd like you to get out of this is that you, an individual family doctor, can make a huge difference in your community. I'd also say that I think the mistake we've made in our efforts to fix healthcare are the triple aim is what Don Berwick and the Institute for Healthcare Improvement out of Boston put together. And they say that to fix American healthcare, we want to focus on better healthcare for the individual. And I think all doctors tend to really focus on that. I want to be the best cardiologist. I want to be the best urologist. I want to do what's best for my patient. But when it comes to the community and looking at how to make healthcare better for everyone in my community, we sort of look the other way sometimes. And then the cost containment and how much things cost, we don't look at all. An example, in my current practice life in a hospice, I had a hospice patient, 88 years old with metastatic cancer every place, in pain, in misery from this very advanced disease, being prescribed a drug that costs $50,000 a month, which the best data shows that it would extend life for 2 weeks over a 6-month period with a lot of side effects. I would say that such an action may have met the patient's goals of trying to extend their life by 2 weeks, but maybe not. And in this instance, it turned out that none of this discussion had taken place. But it costs $50,000 a month, and I think that's not looking at the community, and it's not looking at the costs. Grand Junction, I think, is unique because we looked at all three of those. I also want you to come away with the thought that continuity of care is magic in medical practice. Knowing your patients, as has been said repeatedly in these last 2 days, is so key to providing the best care for the individual. You also need to take care of yourself so that you can get burned out on healthcare and on practicing. And the model that I kind of grew into where, oh, you're a doctor, work 100 hours a week, doesn't work anymore in my view, and you have to focus on that. And lastly, I think the fundamental problem is the way we reimburse physicians, and if we can change that, we will make the most progress. This sort of says it all. In 1965, we spent 6% of GDP on healthcare, 6% of GDP on defense, 6% of GDP on education. In 2009, we're spending 17, 18% of GDP on healthcare. We're spending 4.4% of GDP on defense, and even less on education. That can't keep up. Or another way of looking at this, which Ted did such a great job talking about the high costs of U.S. healthcare, but why is it that we're twice the rest of the world? That's Italy, Japan, UK, Australia, Sweden, France, Germany, Canada, Switzerland, to the left of the red bar of the United States on what they spend per capita on healthcare. That is an unsustainable system. But the Dartmouth Atlas data does show some pockets of hope. So there's Grand Junction hospital referral region, and the lighter the color, the lower the cost per capita. And so there are areas that stand out. Grand Junction stands out in data for costs of drugs, this is Medicare payments for all types of Medicare, and it is sort of a pocket of hope. And here's the raw numbers that pointed out. McAllen, $14,900 per Medicare enrollee versus Grand Junction about $5,800 per Medicare enrollee. These are big numbers of people. That's why the Dartmouth Atlas data is so valuable to us in looking at what's the difference. Why are they so much less expensive? On the quality measures, Grand Junction came out ahead. And so if you're this says heads, you get a quadruple bypass. Tails, you take a baby aspirin. And what's the difference in the way we practice medicine across this great country to account for such huge differences? And you've probably heard all the other stories that this area does 4 times more myringotomy tube operations on children, or this area does a whole bunch more tonsillectomies, but no difference in outcome. And Grand Junction, as compared to the United States, was lower in everything except outpatient services. And outpatient services means going to the doctor. So people in Grand Junction go visit their family physician just as much as the rest of the country, but we do fewer x-rays, we do fewer lab tests, we hospitalize fewer people. We have shorter lengths of stay, which resulted in the findings that I just showed you. So in 2009, we got famous, and President Obama made reading about Grand Junction mandatory, they said, for his staff. And why is it? What did we do? Well, it wasn't a year in the making. It's been happening for about 40 years to lead to this better system of health care. This is a picture that I took of President Obama when he came and lauded our health care system at Central High School in Grand Junction, one of the 4 high schools. So to give you a little geography lesson, Grand Junction is right here, and this is probably in the continental United States the most underpopulated or least densely populated area in the continental United States. Maybe eastern Montana and a few other places are similar. This is Denver, and there are about 5.5 million people in Colorado, and 5 million of them live along Interstate 25, which is Pueblo to Fort Collins, including Denver. This is called the Front Range. That's where all the people live. Salt Lake and Utah, and this is Provo and Salt Lake City and Ogden. This is where all the people live in Utah. And right in the middle of them is Grand Junction, Colorado, about 250 miles over mountain passes to Denver, about 250 miles to get to the outskirts of Salt Lake and Provo from Grand Junction. So we are in the midst of an underpopulated or a low population area. This is Aspen, Telluride's down here, Steamboat Springs is up here. This is Arches, Canyonlands National Park, Moab, Utah, and Black Canyon of the Gunnison. So we have quite a few national parks around us. But that's the advantage that Grand Junction had, I think, in creating this healthcare system. Because lesson number 1 is we could not sort of ignore problems in our community, because where's somebody going to go? They're going to go to one of the 2 hospitals in Grand Junction. That's it. That's the only choice for miles around. This is 15 miles from the city center. It's, there are actually more natural arches there than in Arches National Park. So the big picture of how we got there are multiple, and I'll highlight 8 particular areas and things you might think about doing. Leaders have been essential to our success, and people have stepped up. And when I talk about this success, it might be one person that has the idea, they gather, they get other people, and it's pulled together by a group. And simply to do the right thing. Now that's so such a truism may not resound with you, but I think medicine has not done the right thing. Why don't we have a plan coming from medicine that's explicit, that's detailed, that says, here's what we need to do to fix healthcare? And I would say that such ideas coming from the House of Medicine are lacking, but we should not ignore the problems in our communities. And doctors need to get involved. I think of the Patient Protection and Affordable Care Act. I saw Ted Epperly testify and talk to President Obama about the bill, but medicine didn't write that bill. We didn't come up with the details of that bill. That was insurance companies, pharmaceutical companies, people with self-interest in maintaining the status quo that do this. Doctors should do that. Groups are absolutely essential. The FMEC, the Society of Teachers of Family Medicine, the AAFP, those groups can, with a good idea, help bring things together. And as I've said earlier, think about what steps you can take to make this better, and not the folks in Washington, but local communities. This is my hero. Larry asked me to talk about who pulled this off, and this is Roger Schenkel, and I took a picture of him in our parking lot about 10 days ago. Roger is 71 years of age. He came to Grand Junction after going through, I think, the first graduating class of family medicine residents at Gail Stevens' program in Wichita, Kansas, if I'm remembering right, in 1972 or so. And he came to Grand Junction, Colorado. And Roger has not won awards. He's not been in all over the press, but one doctor can have a huge influence, and this is my hero. I'll talk about him a little later. So the steps that have been done for years and years to make Grand Junction such a high-performing healthcare area is, number one, have family physicians. And Roger, at 33 years of age, when he first got to town, decided that we should have a family medicine residency program there. He wrote a grant, then you could get money to start a residency program. He talked the medical staff into doing this. He talked the big hospital into doing this. And indeed, we had a family medicine residency beginning in 1977. And the first graduates were in 1979. That program has grown to 24 residents, 8 per year, and about 135 of those graduates are practicing in the area in western Colorado. Bob Wergen, who was elected a couple of weeks ago as the incoming AAFP president, he practiced in Grand Junction for about 10 years, and then because of football team and the University of Nebraska, moved back to Nebraska, but I'm proud to say he's a graduate. Back to this program, you've got to produce your own doctors if needed. There is no graduate medical education program between Provo, Utah, and Denver, Colorado. So if you're looking for doctors, a good way is to produce your own. A second real important component of making this quality healthcare system is the focus on quality. And Christine Peterson, when I first got to town, I was then 28 years old, and she talked me into being on the Medical Practice Review Committee of the IPA. And nobody was doing that, as far as I know, across the country, but I went as a I think I was 29 when I got on the committee, going in to look at offices of 65-year-old general practitioner, family practitioner doctors and looking at 20 charts and trying to rate them on their healthcare quality. That effort has not stopped in all these years, except we've gotten much more sophisticated in doing so. But throughout this entire time, we look at physicians and their practices very closely, and this makes them better. Today, computers do a lot of that, but we can, for instance, look at the costs of orthopedic surgeons doing knee replacements. And we can list all the orthopedic surgeons, and then we can tag to them their costs of care, and you'll find that this orthopedic surgeon is twice as expensive as that orthopedic surgeon. We do the same for pediatricians, for family physicians, rating them on quality measures and cost measures. And believe me, when a doctor sees that they're at the bottom of the list, that their quality is not as good, such as my patients aren't getting mammograms, my patients aren't getting colonoscopy or colon cancer screens, or my patients are not being vaccinated up to the par of the rest of the patients, I want to fix that problem. So it doesn't require a lot of punitive measures, just having that information helps. And then obviously the cost data is absolutely an eye-opener when you find out that one orthopedic surgeon costs twice as much to do something as another. Guess who's going to get all the future referrals? The ones that are cost-effective. So quality data and cost data is better, and it meets the idea that we all want to be the best. Obstetrical care was another one with a great idea from Janet Grant and Steve Meacham and others in my community. We all know that prenatal care saves lives. It saves in premature babies. It saves total health care costs. And so what are we going to do about that problem? And they came up with a program called B4 Babies, such that one telephone call to one number got someone who was pregnant into a doctor within a week. Didn't matter whether they had Medicaid or no insurance, they got seen and they got treated. The doctors that practice obstetrics in the community all took turns in seeing uninsured patients, but it was good for the community and it was good for the people involved. This is Colorado National Monument, which is right outside of town. Another key thing in making our health systems more efficient are better information. Ted talked about this yesterday, and it's absolutely essential. Ted talked about why is it that he can get cash in 20 seconds from some European nation, but he can't find the medical records when something was done yesterday in the emergency room. Well, we recognize that problem too, and so we created the Quality Health Network. This was done that the state of Colorado had habitually underpaid our region's physicians for their Medicaid services. So after 10 years of it nicely asking the state to pay up, and they didn't, we sued them. And we hired an attorney, and we went, and after about 2 years of legal maneuvering, the state paid up. And so the physicians took the $2 million of that money that was paid back, and we created the Quality Health Network. And that was a program in which we designed what information do you need to provide great care. And it's the lab tests, the x-ray tests, the advanced directives are on this, the prescriptions filled, so that every pharmacy every hospital that prescribes drugs feeds this database. The discharge summaries from hospitals, the emergency room notes done, all get populated on this QHN database. Then, if the patient comes in to see me the next day and says, well, I went to the emergency room last night, they prescribed some pills, I don't know what they are, they did some tests, I don't know what they are, bingo, I can look it up. It's an internet accessible to get on the QHN database and find that out. That has been huge and is growing. QHN now serves pretty much all of Western Colorado, all the 500,000 or so people in Western Colorado are part of the database, and it's been a huge improvement in having the data to make the proper decision for your patient. Pharmaceutical costs are huge in our healthcare system, and this too has been instituted by a family physician. I'd give Dr. Phil Moeller the credit more than anyone else, but many, including pharmacists, have been involved in informing us about the costs of drugs. So the first thing is that in all areas of medicine, if we're going to change the system, the first thing is, what does something cost? My little rule of thumb is, if you ask a cardiologist what's an echocardiogram cost, you ask a gastroenterologist what's an endoscopy cost, you ask a surgeon what an appendectomy costs, whatever they tell you, multiply it times 3, and you might be a little closer to the right answer. They don't know what things cost, let alone the costs of drugs and services they order. So we tried to shine a light on costs throughout the healthcare system for all of these years, and drug costs were a fairly good target. We also did lots of programs to encourage using lower cost drugs. For instance, our IPA, when it was a brand new thing, Hippocrates, paid for every doctor to have a handheld to have Hippocrates on it, so we could look up the formulary and see the cost comparison and realize that one ACE inhibitor costs 4 times more than another ACE inhibitor, or one newest antidepressant costs 6 times more than a generic over-the-counter antidepressant. So giving the tools to physicians so that they know the costs was important. And then we have a monthly talk called Pharmaceutables, and that is a very well-attended conference by family physicians to kind of learn what's the newest and the greatest, and sort of the deceptive sort of advertising that pharmaceutical companies do, which is so prevalent throughout our healthcare system. When you looked at when we saw the data from some of the costs, which I showed you earlier, where our real problem is in people with chronic diseases at the end of life. And if you can't read it, the green line is Germany, the blue line is the United Kingdom, the yellow line is Sweden, the dark line at the bottom is Spain, and guess who's the red line? The USA. So what are we doing about that? Well, all the major players or organizations in Grand Junction recognized this and said, you know, this palliative medicine is a darn good thing and something we should do. So together, the hospitals put in money, the physicians put in money, Rocky Mountain Health Plans, the local insurance company, the Veterans Hospital put in money, and together we formed a hospice. And that was in 1993, and today this hospice that now I work for, full disclosure, we have 300 employees, we have about 410 active patients, we have about 200 palliative medicine patients, We do consults in the hospital, palliative medicine consults, and I think collectively this has had a huge impact on our healthcare costs and our healthcare quality. We also cover, go down about 100 miles away is Ouray, Colorado, and so it's a huge geographic area, but hospice and palliative medicine is part of the solution for cost-effective, high-quality healthcare. We also have a volunteer effort where we have physicians that are retired go around and talk to groups about advanced directives, and I think that's one of the trickiest things. Advanced directives is not do not resuscitate. That is not you need an entire conversation with the patient, with their family, and sometimes involving their subspecialists treating people to come up with a care plan and an advanced directive that really makes sense. I think our entire country needs to do that. We need to do that better in Western Colorado, but absolutely essential so people don't die in hospitals and ICUs with chemotherapy dripping in their veins as they die. Another real key thing in Colorado has been defensive medicine and how to control that, and we passed the best healthcare reform or tort reform bill in 1987 called the Healthcare Availability Act. It was started in Western Colorado. The movement basically, with the tort costs going up, it was going to be like the only place in the state that could afford to do obstetric care were the big cities in Fort Collins and Denver, and you can't have pregnant women driving 200 miles to see the nearest obstetric provider. That enabled the momentum to get a tort reform bill passed, and the cost of malpractice insurance in Colorado is still one of the best in the nation. And I just want to throw out that whatever we do in health reform and fixing things, that the fee-for-service system does not work. It incentivizes the wrong things. And we have made inroads into that in Grand Junction. For instance, the subspecialists gave up money to pay family doctors a little bit more. Not a huge shift, but some. Another thing that was done was we wrapped all the patients into the same system so that through the IPA and through Rocky Mountain Health Plans, if a patient had Medicare, if they had Medicaid, or they're insured by their employer group, they all are members of Rocky Mountain Health Plans. And so I, as a doctor, don't care whether the patient has Medicaid or private insurance or Medicare insurance. I'm going to get paid the same fee for the same service. I think that is essential because big cities and the rest of America suffers from, we have the Medicaid clinic, we have the federally qualified health centers, we have all these different silos of health care leading to unnecessary costs. This is the medical industrial complex of Grand Junction, Colorado. That's the big hospital and most of the doctor's offices. I was just off the picture to the left in the low rent district of doctor's offices there. All this is not easy, and things that are barriers to doing success in communities. One was the Federal Trade Commission. In 1997, the FTC came knocking on our doors and said, those poor insurance companies are being hurt by all you doctors collectively working together for health care of your community. So we're going to sue you. And talk about unfair. I was the doctor representing us and against this FTC suit, and that was really a bad thing. This is where groups are so essential. I'd give a big pat on the back to the American Medical Association. As soon as we got sued, I went off to Texas and talked to Nancy Dickey. She was then a family physician president of the AMA. She said, this is the reason the AMA exists, is to protect doctors like yourself. A couple of days later, she sent out lawyers to Grand Junction. The new Federal Trade Commission antitrust law, they looked at what we had. She said, we'll defend you, we'll pay for it, we'll support you in every way possible. The AMA pulled us out of that trouble and was great. Just like other organizations, you sometimes need that help. We've had a couple of leaders that I'd say were selfish and offer their own financial gain. That hurts. You've got to get rid of those people. You have to drop things that don't work. I don't think you can pay doctors fixed salaries. We're just like everybody else. If you pay me a lot of money to not work, I won't work. You have to have the productivity behind it, and so we being the hospital, bought practices in outlying areas. Doesn't work. I think boutique practices are sort of a plague on our profession of family medicine. When we get too much that we want to super subspecialize and just treat one type of person, we're really not family doctors anymore. A family physician takes care of any undifferentiated patient, in my view. A person that's sick, they'll help them. We've had quite a few failures. This has not been entirely successful. That, for instance, recognizing the shortage of doctors in general, we tried really hard in 2007, 2008 to open a 25 medical student branch campus of the University of Colorado. That has not yet happened yet. We've tried numerous efforts at a whole different way, totally different, of paying physicians. We've made inroads, but we haven't done that. And the medical arms race, which too many CAT scans, too many MRIs, too many hospital beds, too many subspecialists, that kind of problem is very hard to fix because we don't have any way to sort of police against it. But for instance, somebody in Grand Junction is now building another hospital to duplicate the services at the larger hospital. Total $50 million waste of money, and guess who's going to pay that? The citizens of Colorado. So we haven't been totally successful in other areas. I think sometimes that specialists and academicians just don't get family medicine. And so much of the magic of family medicine is continuity of care. If I've taken care of a patient for the last 10 years, I know their wife or husband, I know maybe their children, I know what they do, I know about them, I know their particular, this person will take pills, this person won't take pills, this person likes a lot of tests, this person doesn't. I can take care of that person better than anybody in the world because of that continuity of care that we have. That needs to be preserved in family medicine. And also that the follow-up in the continuity is so key that I don't know of a case where I made a huge mistake in medicine where I totally missed the diagnosis. But I could probably tell you about hundreds of cases where it took me 1 day or 2 days to figure out that this person was really sick and needed hospitalization. A boy came into me with a cough, sore throat, 21 years of age. It took me about 6 hours to figure out that he had a huge lymphoma in his mediastinum that was obstructing his airway, and he was about to die. And those kind of so much of family medicine is knowing your patients, knowing what changes they have, and then not to do huge workups or emergency room workups on those that are going to have self-limited illness. Kind of my way of looking at the world, that we're upside down. We emphasize tertiary care, and we don't do primary care. As Ted said so eloquently yesterday, the rest of the world does it just the opposite, and that's why they're more successful. Be educated about the costs of health care, and you have to get that data. Believe me, hospitals don't want you to know what they're charging. Specialists don't want you to know what they're charging. Figure out ways to get that data and publicize it. Let others know. It'll make a difference. And you're blessed being physicians. You're a thought leader. What you say matters. People will accept you as a credible, knowledgeable person. That's a huge advantage, but we need to speak out and, of course, learn from others that you admire. Just a quick overview. The Affordable Care Act is about the best thing that could have happened, because 50 million uninsured in the United States is just a moral tragedy, and those people will start being insured. If you have, like, your 21-year-old with juvenile diabetes, you can get affordable insurance. You're also given freedom through that bill, because now you can start a small business and not be shut out of that possibility by outrageous health care costs. Isn't that a good thing? And insurance companies, because they can't underwrite like they've been doing for the last 50 or 70 years, they now have to focus on efficiency and quality. That's a good thing. And the Innovation Center of CMS has got all sorts of interesting projects going. Isn't the Affordable Care Act wonderful? Well, no, because it doesn't change how medical care is organized, paid for, or delivered. So what's so bad about the Affordable Care Act is, we heard earlier from Ted, and I'll say it again, that we consume about 30% of those $2.7 trillion. Here on my slide I wrote $2.3 trillion. Sorry for that mistake, but if we spend 30%, the rest of the world spends 10%. That's $460 billion a year. I would estimate that defensive medicine costs about 20% of what we do. The Institute of Medicine, by the way, says $760 billion a year is wasted in the U.S. healthcare system. That wasn't fixed. The medical arms race, the overbuilding of hospitals, the too many specialists, that is a big problem. The lack of incentives to go into family medicine and primary care is a huge problem, and no one has really addressed fetal end-of-life care except for our hospice programs, which are just kind of starting that process that so badly needs to be done. So the Affordable Care Act has not solved tons of problems. And as Einstein said, doing the same thing over and over, expecting a different result, is insanity. And the Affordable Care Act, in a way, puts people into this insane system that we have not yet fixed. So you, the younger generation, have a lot of work to do. And I like the quote by it's not enough to do our best. Sometimes we have to do what's required. So many steps need to be taken to really fix American health care. And you never change things by fighting the existing reality. To change something, you must build a new model that makes the existing model obsolete. I think Dr. Epperly did a fabulous job in describing that newer model of health care based on primary care, based on health. That's what we need in our society. Thank you very much, and I'll welcome any questions if we still have time. Thanks.
We have time for one question. Do we have a question?
Hi, my name is Jason. I'm a fourth-year student from Rowan School of Osteopathic Medicine, used to be known as UMD&J in New Jersey. Thanks so much for coming to speak to us tonight. I just want to let you and everyone else in the audience know about a new bill that's been proposed in the New Jersey State Senate. It's called the New Jersey Volunteer Physicians Protection Act, and what it does is it allows, if a doctor volunteers 4 hours of his or her time per week in a free clinic, then the state will take the state will basically pay the malpractice insurance of that doctor, not only for the time they spend in the free clinic, but also their private practice. And the hope is that people will be less likely to sue a doctor if they're being covered by the state, and that more doctors will then be incentivized to take care of the uninsured, the illegal alien, and just any poor person. So I don't know if you've heard about this act. I don't know what you think about it, but I think I also want to know more about how you guys did the tort form in 1987, how exactly that happened.
The kind of maybe not directly addressing every issue you brought up, but one about we don't need tort reform as much as we need an alternative dispute resolution system, because tort reform gets malpractice premiums lower. It allows doctors to practice obstetrics and go to the emergency room, do a broader spectrum, which is great for patients. But I'd ask everyone to look at what they did in New Zealand. They had similar problems, and they have an entirely different system. So you think that the hospital or the doctor did something wrong or difficulty, then it goes to a special arbitration dispute resolution system, and that's the only way we're going to get rid of defensive medicine. For taking care of anybody, the people with no insurance, the people with great insurance, legal immigrants, illegal immigrants, all of that, some of that's going to be solved, of course, by the Affordable Care Act, but I'd say that that's just indicative of the problem that, as T.R. Reid said yesterday, that most countries, if you're in that country, you can get health care and not pay through the nose of it. I've had friends get sick in Thailand, get sick in Israel, get sick in France. They're American citizens, and their health care is pennies compared to ours. A good health care system stops the cost shift from those with different types of insurance, and instead the health system takes care of everyone in a cost-efficient way. Ted.
Yeah. If you'll allow me one more question, Larry. First, David, what Grand Junction has done has been fabulous. It can't be lost on everybody in this room how big of a deal this is as a national model of how communities can start to get things right. So my question to you, David, so much work has gone into this, as you've said. It's the tip of the iceberg. It's years of work moving forward, which is great. Let's skip forward now 10, 15, 20 years in Grand Junction. What does healthcare look like 5, 10, 15, 20 years from now in Grand Junction, Colorado?
Everybody has a family physician, is probably number one. Those family physicians are the entryway into the healthcare system. We've accomplished that to a good degree, but we need more of that. We need more physicians that think like family physicians. If you look at national data or studies like from the New America Foundation on Grand Junction, they point out that we only have 1.3 times the number of primary care physicians as the rest of America. It doesn't stand out. But when I did a study, we have twice as many family physicians. Grand Junction has very few general internists, relatively few pediatricians, lots of family physicians. So one answer, Ted, is have that strong primary care base, the patient-centered medical homes, which I think pretty much all of our practices have accomplished already. That is an absolute key. The other thing is shining a light on the costs of care. I think if our society really knew that a chemotherapy costs $250,000 and will make the person sicker than, vomiting, nausea, and might make them live for one more week over a 6-month period with a terminal cancer, I think our society will start making better decisions about spending our healthcare dollars. Thank you.